I'm sure Professor Khaled or Professor Jallali also detected many times small bowel lesions, and they detected it. We will talk about a good laparoscopic diagnostic laparoscopy later. But overall, because a good examination of a small bowel by laparoscopy is a high, needs a high education. What did you think?
About control of the bleeding.
Control of bleeding. Yes. Control of bleeding is also, it depends of the degree of bleeding. Small bleeding and could be controlled by all of you. You have had many times bleeding from bed of liver or other parts. For example, ovarian system, you want to do cystectomy, laparoscopically, you have some bleeding. But these are not very disturbing, and you can control them, although when we have a blood, our view will decrease because of absorption of light by hemoglobin, and suddenly your vision will be decreased. So controlling of bleeding very important. But I tell you, and not only I saw many persons control, but by myself I have controlled IVC, superior mesenteric vein, and also splenic injury. The last one was splenic injury that I had. Only in 1 minute we had about 1.5 liters of blood bleeding, and we controlled it completely by laparoscopy because of the splenic injury. During our surgery, but overall, if you have any doubt about controlling the bleeding, you should open the abdomen, because the safety of the patient is the first.
Which occasion you have good control by laparoscopy for bleeding, and at which occasion you have control of bleeding by open during your laparoscopy?
I think the most important is experience of the surgeon. But which occasion, you need a good team. In last month, trauma to spleen during my surgery, by my assistant, I put 13 gauze, completely gauze, 4x4 gauze, inside the abdomen through the true car, and pack the spleen. In about 1.5 minutes. About 2 minutes, I put 13 gauze continuously.
Do you have film on that?
Yes, yes. But not, I
saw it. Yes. But the team is very important. If you work by a nurse and there is ability, she or he cannot help you. In this situation, that doctor works with some assistant, some fellowship, help him, and
God also. At first, God helped me.
yes. God and the fellowship help doctor to control. In laparoscopy,
He is Moshe, God and Moshe.
Yeah, the direction. Moshe. ماشین ببینید تو ماشین important things is the prevention. In laparoscopy, the most you should go very cautious, and the prevention of bleeding is very. It's not like laparotomy that you
Prevention better than repair.
prevention. You should be very cautious, very slow, and take care and everything. And also everything should be ready. For example, in some, I saw in some operating theater, there is hemolock, you know.
Yes.
Hemolock. You cannot put hemolock in a vessel that will bleed. Because in hemolock you should circulate and see the other part of the vessel. You need metallic clips. Everything should be ready when you want to do every laparoscopy.
So, in conclusion,
I want your opinion, Professor, about the
first, the surgeon is an expert, and his team is also expert. His facilities available, and all of them controlled by God. Then you control bleeding by laparoscopy. But if not, sometimes even severe bleeding, you can control it better by laparoscopy rather than by laparoscopy. Am I right, sir? For example, if you have bleeding from a splenic
I haven't talked about this topic, which are better controlled by laparoscopy compared
That's
to.
my question. Which is better controlled by laparoscopy?
I don't know. Really, I don't know at present. I should think and also search.
For example, if they have injuries to iliac muscle,
Yes.
during the joint injury, they
Yes.
should not convert immediately to open surgery while they are not controlling the bleeding. They should control the bleeding first by laparoscopy, and if they succeed, they can proceed with doing the repair. But if they convert to open immediately, they might lose the patient. And during your conversion to open, you might get a lot of bleeding that you can lose your patient. So try
Sorry,
immediately
sir.
advance.
This is even with the camera board?
Yes, even in the camera board.
Some surgery said that in laparoscope, the pneumoperiton will give a pressure, will decrease the bleeding. And if you open, the tamponade effect of hematoma will lose.
But every time, but yes, the pressure is good. But if you have, you know, we talk about the pressure, and it's mostly between 12 to 14 millimeter Hg. And if you have a venous bleeding, it will help you. But when you have arterial bleeding, it cannot control it. And hacking is very important.
Doctor, Safa,
Good.
I have an experience about sort of about the pressure of pneumoperiton.
Yes.
This topic is about, for example, when you go and injure the aorta or iliac muscle. What do? Open the abdomen? No. First, no. First, I have some experience about. First, you should increase the pressure of intra-abdominal pressure. And because if you in all time you don't have any instrument for, you should prepare yourself and your team for a big catastrophe inside. Then that everything, vascular clamp and everything is ready. And when you first open or switch off the laparoscope, it's very dangerous because the bleeding may be very high. And if after preparing, you should open and in big bleeding, not in a small bleeding. For example, a splenic injury, or you can do by laparoscopy packing and try to resolve problem by laparoscopy if you have good experience. But if you don't have, don't decrease your intra-abdominal pressure till all instrument is ready. And after that, and your colleague come and another person come to help you, after that you open and go and repair.
What's your opinion when the patient has hypotension? You see, the anesthesiologist tell you that the patient blood pressure dropped, and drop, suddenly drop. I think in this situation,
In this
we should
situation,
open.
the cause,
If the
the
patient,
cause, the cause of dropping the blood pressure is the hypovolemia, or maybe pressure is abdominal pressure.
if you have bleeding and the patient goes to choke, I
You
think
should open.
you should open without any delay. And as soon as possible, but we should search and do some, I think, research about this to have a good result. Yes.
When Dr. Safa talked about when the bleeding is very severe, we before opening the patient, the same thing that you said, we must take gauzes inside and pack the site of bleeding and then open the patient, because we cannot open the patient very quickly. And in this time, if the bleeding is very severe, the patient may be lost.
Yes.
So before opening the patient, if our judgment is that the bleeding is severe, we must pack it. And
How do we pack it? It was this scenario. We with the first true car, we entered the aorta or iliac, and there is a massive bleeding. If you want to do this, you should
On the
do.
camera itself, I can see nothing.
Yes, but at first you should
External pressure.
if you what
External pressure.
external pressure won't help you. Mostly it won't help you. If you want to do this, you should put a 12 millimeter, not 10, not 5 millimeter. 12 millimeter port, about 7 to 10 centimeter away from your optical true car, and then put gauze inside the abdomen and compress it and then open the abdomen. It will help you to prevent catastrophe.
I'll give you one example, Ustad.
Yes.
Just as a troubleshooting. I wanted to do laparoscopy for a patient having two iridices. One of them is obvious, reaching the surface of the liver, and the other is intraparenchymal. So I finished the first and I tried to reach the second. And after I put my needle in the parenchyma of the liver, I diagnosed the site of the hydrated, and I tried to enter by a larger trocar inside the liver, and suddenly I have very severe bleeding coming from the trocar. So the first thing I did, I put several surgery inside the trocar. Through this trocar, I took the opportunity of the trocar is reaching the bleeder, and I put surgery, a lot of surgery inside, and the bleeding, I wait for a while, for 5 minutes nearly. Then when I withdraw my trocar, the bleeding was.
I think we can classify to different large vessel, arterial bleeding, venous bleeding, and solid organs bleeding. Sometimes we have mesentery bleeding that may be very high, especially in the base of the mesentery. We had a case that our fellowship entered by first through car, and we opened the patient and compressed it, and it was after when the vascular surgeon came and we saw the bleeding site. It was only branches of the superior mesenteric, inferior mesenteric vein, but superior mesenteric vein. And it depends. We should, at present, I think each surgeon should decide depending the situation. And at present, I haven't seen any classification. But for liver, I had many times bleeding from instruments, and although at first the liver bleeds very severe, but most of time it will be stopped. Yes.
So for me, I'm not so expert in lab coding, I saw my senior Dr. صفاء, he controlled bleeding in lab colon simply. So if I'm doing a lab colon and there's bleeding, for me, I will clip the common bile duct.
Yes.
So it is better for me to
Yes.
open.
Maybe.
Yes.
Maybe.
I'm not
Of
so
course,
sure.
sure.
Yes,
But
I
hacking,
Dr. Safa,
different types of controlling of bleeding are very important, and I think we should in future have a special topic for bleeding control.
This is a good question.
Yes. Yes.
It was that for me as a beginner, for example, I have bleeding I cannot control. Open is the best choice. Sure. Because the opening.
No, I'm not sure.
No,
Because for beginner, yes. For beginner, yes.
For beginners, yes. For beginner. Because in the when you bleed in cholecystectomy, because the cholecystectomy is the very common procedure, and every surgeon more than another procedure that you do, yeah. And common bile duct injury is very important. If you cut common bile duct, like my mentor told me that when you cut the common bile duct, like you create a cancer for your patient. This is a big catastrophe. One of my mentors told me, cutting the common bile duct like creation of a cancer for your patient. Like this. Stricture, some problem in the future. And in this situation, you should open another valve and see and do what you did in the past.
After using pressure, after using the first step of pressure,
Yes, gallbladder. In cholecystectomy, you cut cystic artery, for example. Cystic artery bleed very much, especially in laparoscopy. In laparoscopic view, when you see the cystic artery, you have the cutting the cystic artery. I had in the past when I in the first cases. Very dangerous. You should open the patient and do your job.
Two tricks that I can add to Professor's speech. I have very good experience for controlling bleeding with single action instrument in my left hand. Because double action, we have the instruments, some instruments have double action tip, some have single action, only one blade moves. In single action, you will have more pressure in tip of your instruments. When you grasp, you have more tension, and it will. I have many good experiences for controlling bleeding with single action in my left hand, and most of the time I recommend my fellowship to hold single action their left hand. Another thing is packing. Like open surgery, every time you have bleeding, don't delay packing the site. It will help you for controlling 5 minutes pack, and then with a good suction gradually and a good assistant, and putting maybe another port every time you have bleeding and you think you cannot control it, putting another true car will help you to have good assistant for controlling. And one person can come, for example, when we had an adrenalectomy and the adrenal vein base just on the IVC was sloughed, and at that time I did by ligature, and it's a mistake to coagulate the right adrenal vein by ligature. It will be sloughed and you will have bleeding, and I'm glad that at the end of operation, when I was washing the site and no bleeding, suddenly a fountain of blood was created, and by single action I grasped and my assistant put a good suction and ultimately we sutured it laparoscopically. This I can add to. Do you have any recommendation? So we talk about the contraindication. You know, most of time you can do all the operations laparoscopically, and as the time is going, we have previous contraindication as indications for laparoscopy. As I told, for example, obesity, previously they talked about it as a contraindication, relative contraindication, but at present we have a good indication of laparoscopy. For example, for GYN, at present I know that they tell that GYN malignancy are a contraindication to laparoscopy. As my knowledge, I don't know the new edition of GYN books, but I'm sure that in future it will be changed because, as you know, previously we talked, we have some port site metastasis because of removing the specimen from small incision, made port site seeding. But at present we put inside the bag, and also we have wound protector, and really we have done near all the GI cancers by laparoscopy from stomach. In colon, you know, at present most of references tell us that the laparoscopy is better than open, and you can do as radical as open surgery for such cancer, and better. You really, it is better done by laparoscopy. You will do lymph node dissection and radical resection of the tumor. But I want to know about the contraindication of laparoscopy. What's your opinion on when we should not do laparoscopy? What? Coagulopathy, yes. Coagulopathy is a contraindication, but it's the same for open and laparoscopy if you have. But especially for child C, you know, when the patient has cirrhosis, child A and B may have some coagulopathy, but you can control it by laparoscopy. But child C, because high risk of bleeding, is a contraindication to laparoscopy.
In the past, coagulopathy was absolute contraindication, but now it's relative. Now it's relative. Because contra bleeding in laparoscopy is difficult. Than the open.
Scarring on the previous operations.
Adhesions was no. I talked about at first about absolute contraindications. Yes, if you have less experience, it's better to do open. But I think some of you have done some patients who had previously some surgeries, and I think I had some cases, many cases.
It's not
who have
absolute.
About 10 cases that they had 4 operations before doing my surgery for them. What's your opinion about that? And especially for incisional hernia. Incisional hernia, we have some cases that have 7 times open surgery and then refer to us for laparoscopic surgery. So, do you have any experience for previous surgery?
Previous surgery in the past, like coagulopathy. In the past, previous operation was the contraindication of laparoscopy. But now, this is relative, but in some operation, like incisional hernia, the treatment of choice. Now, the treatment of choice for incisional hernia is laparoscopy. In all, for example, you did some laparotomy, some for cancer, for everything. Now you have incisional hernia, and there is adhesion. But the laparoscopy in patients that have previous surgery is more difficult. You should go, first entry should be very cautious. If you go inside, you put another and lies the adhesion and go inside. But there is not absolute country.
Because there is a scarring in the umbilical region, and the too much scarring in previous operations.
Yes. You should go in another one.
If the gastric, you can go, the camera will be should be gastric.
No, not every class. Mostly we put a varus needle in left upper quadrant, or if you have enough experience to work with optical trocar, you can go away. Mostly I go away from the incision from left side with optical trocar and enter the abdomen. Or if we have incisional hernia, away from the opposite side, we enter the abdomen by optical trocar, or sometimes open. Yes.
Most of the laparoscopic operation need general anesthesia.
Yes.
We cannot do laparoscopic in local or spinal.
It's very few cases
Few
they
And
do.
therefore, till now, if the patient cannot withhold general anesthesia,
Yes.
that's going to be absolute.
Yes,
contract.
yes, yes,
Limited respiratory reserve.
yes.
Limited respiratory reserve.
Limited respiratory reserve. Yes.
Liver impairment.
What?
Liver impairment.
Liver impairment. Yes. And we turn to pathophysiology of gas and insufflation. You know, we use CO2, and when we do insufflation, it has two most important effects. First, its effect on acid base. It will make the patient a little acidotic. And, yes, yes. And the hypercapnia. Another thing is the pressure and its effect. You have pressure inside the abdomen, it will move the diaphragm above, and yes, yes, and all of your respiratory volumes will decrease by this pressure, and also this hypercapnia makes your patient to be a little acidotic. But when we can tell the patient you are not a good candidate, if the patient, you know, we do many, a very good indication of laparoscopy for morbid obesity surgery. And you know, asthma is a comorbidity of morbid obesity. And we have many cases that come to us and they have asthma. And if we want to do open operation, open surgery for them, it will be very difficult, both for the patient, even his respiratory problems will increase with open. So, if you have severe COPD, asthma, bronchiectasis, other problems of respiratory tract, it's better to do open. But we have done many cases of mild to moderate COPD that we have operated for them. You should know that with increasing the rate of respirator, you will help the patient to wash the CO2 from the body, and it should be till 20 times per minute. More than 20 times, you will have less time to for exchange of gas from. So you can, you know, most of time in open surgery they put the rate of breathing, for example, 14 But if you have hypercapnia, that first, for laparoscopic patients, it's really mandatory to have capnograph. And if you have hypercapnia, at first they should increase the rate of ventilation to 20. And then, how about this?
So, regarding the question of the Dr. about the, his comments about the contraindication of laparoscopy and spinal anesthesia. This has been mentioned in textbook by, for example, Mishra. It's contraindicated to do laparoscopy, for example, for hernia and spinal anesthesia. I think this is not correct. We, over last year, we did more than 100 cases of back query. And even lastly, we did laparoscopic CPD acceleration under spinal anesthesia. And the patients recover very smoothly and they are very well. They only complain of right shoulder pain. Right shoulder pain. And this can be simplified by analgesia only.
Yes. Yes.
I think this is not
Thank
a
you.
contraindication for
Yes.
laparoscopy. Spinal anesthesia is no more contraindication for laparoscopy.
Yes.
Spine.
With the spine. Anesthesia, we can do even lap coding.
In some cases, do you do laparoscopic herniorrhaphy by
Yes.
spinal?
Spinal anesthesia.
And some references recommend to do such
I don't-
operation, for example, hernia by N2O, but instead of CO2 in N2O. And how about cardiac problems? When a patient comes to you with cardiac problems, when do you tell him it's better to do this operation for you by open technique? You know, there are mainly two types of cardiac problems. Ischemic heart disease, if it is very severe that the patient cannot tolerate the operation, there's no difference between open and laparoscopic surgery, and he should go for angiography and angioplasty, open CABG, and so on. But if the patient has heart failure, if the cardiac output is less than, and ejection fraction is less than 25%, it is recommended to do the operation by open surgery. And I think I talked many.
About spinal or epidural anesthesia, the operation is very. I did several times laterally by spinal and epidurals. But for hernia, because you should put patient in 20-degree head down. It's very difficult operation, maybe. But the experience of Safa is very much. We can, but I think.
But I will just comment about the position. First, we fix the spinal anesthesia because you know all the time the drug is fixed to a certain level. Then you are free to do
After some
yes. So you start by the boards and then you make your theater field. Then after a while, the anesthetic drug is fixed to a certain level. You can do changing the position.
Yes. I know. I did some cases by laterally by spinal, but in comparison to general anesthesia, you should do very fast and you should have a better experience.
I think it has its own learning curve. And you know, Professor Kalbasi in our country has done many cases by spinal, and he tells that it's very good and I don't have any problem. But because we have only, I didn't have done any by spinal anesthesia. But if you do, I think, more than 100 cases, you will be familiar with it and we can do it. It will have its own tricks. About control, yes.
Just about the patients who have comorbidity, regarding the difference between open and laparoscopy. If we can achieve this balance, we can do the laparoscopy. The patient have better recovery.
Yes. Yes.
Even
Very
if he has
better.
even if he has asthma.
Yes.
If we have an incision, for example,
Yes.
normal incision, and he have asthma, there's too much embarrassment for his respiration. While if we do laparoscopy and small anesthesia, it recovers very well. I think it's better now.
That's completely true, yes. Very important. Some anesthetists told you that this patient is very old and they have some
Yes,
problem
yes,
of
yes.
heart, and
Don't
they want to
think-
put anesthesia epidural or spinal. But in the next day, what happened in the next day? If you open the next day, tomorrow you have problem with anesthesia. But in laparoscopy, when you finish your operation, after
The problem only
problem
during
is over.
anesthesia.
it's very important.
Post operative problem is less.
Yes. And believe me, age is not a contraindication. Many times anesthesiologists have fear about the age. She's very old, she's very old. It's better to do it open. Don't agree with them. We have, I think, some cases over 90 years old and we did laparoscopy, and really the laparoscopy is the best procedure for them that can tolerate the operation. I think we have a break and then I will continue with the tower. Yes. And if possible, I want to a blackboard with a pencil to write. Is it possible to write?
Possible, yes, possible.
Thank you. Thank you. Good break, thanks.
Please speak about the increase of intra-abdominal.
Oh, yes, yes. Yes, yes. I will tell.
Decrease venous return.
Yes, yes.
You will say that abdominal. Decrease of intra-abdominal. Decrease the venous return.
Maybe